my 12th year in Vietnam, I think, 7 times, and I'm happy to also be able to present a technique which I know you are very aware of, although I know it's not so much presented in Vietnam. Can we start the presentation? Okay. It's called mitral and tricuspid transcatheter edge-to-edge repair. Which patients benefit from it? And I hope. How can I move on? Okay. This presentation is based on the publication of the European Guidelines for the Management of Valvular Heart Disease, which have just been published at the European Heart Congress in Madrid, and it included a number of novelties with reference to the M-tier and T-tier treatment, which I will present to you right now. The first novelty is that for long we have Can you start the movies, please? Can you start the movies, please? And put on the right slide also. For long we have thought there's only, right, okay, 2 types of mitral regurgitation. One is the so-called structural primary degenerative mitral regurgitation, and the other one had been called the secondary ischemic or functional mitral regurgitation. Now, having performed thousands of procedures with MTER, we know that the primary still stays a type of its own, but the former functional MR is now called either ventricular or atrial secondary mitral regurgitation. And that is due to study results which examined the treatment in those MRs and due to different characteristics they see. You see in those movies here that in the middle picture you have a somewhat reduced ventricular function and not such a enormous MR, but watch that and keep it in mind. These are the patients which benefit a lot from MTR procedures. The atrial MR more is like an extreme form of diastolic dysfunction or hypertensive heart disease, HFpEF, and often goes along, and I've shown it in this picture too, also with tricuspid regurgitation. So in the guideline now, it's very beautifully designed how the echo should go stepwise by a qualitative to a semi-quantitative and then to a quantitative assessment of the MR. I will not go through all the details, but then should also assess the mechanism, whether it's a primary or a secondary, and if it's a secondary, whether it is a ventricular secondary MR. It defines clinical and echocardiographic criteria for that. I will go through them, or whether it's an atrial secondary MR. And it says in the text, when quantifying the ROR and the right ventricular volume in secondary ventricular MR, lower thresholds should apply to define severe regurgitation. That is because they may already benefit from treatment with MTR. But now let's start with primary MR. Primary MR has long been known to improve survival when it's treated by early surgery. And the first study that challenged that with the MTR, as you know, was the Everest 2 trial, and had shown that MitraClip is equal to surgery, but had been associated with worse long-time results. So we stuck with surgery, and this is still valid up to now. There is many patients, especially in our older population that we treat in Europe, which are, can you click on the movies again, please? Click on every image. No. Which are unsuitable for treatment, either because the valve is has no posterior leaflet as seen in the left upper picture, or it's very calcified, or there is stenosis. So these are patients which are not well treatable by MTER and also not by surgery. Especially MTER is not very well performable if there's a high degree stenosis, as in this case 6 millimeter mercury. So, I'm sorry, I'm not used to this. I'm also sorry that I just spent a long night on the plane. So the treatment of primary MR, as I summarize, still has to be treated with a surgical repair. And there are many questions, in my opinion, that are not answered as now well. We don't know whether transcatheter valve replacements will perform even better in those patients in the future, especially in those patients where surgical repair is not possible and the valve has to be replaced. I would wish for a study which compares valve replacement with MTER, and I'm really wondering what would be the outcome. So another question for me is also in the guideline that which is performed in some specialized centers in Europe, the minimally invasive surgical repair, which is very good for the patient, did not receive a high recommendation. It only received a 2B type B recommendation, off pump. Yeah, many surgeons can't do it, obviously. So now let's come to secondary MR. There's a new classification, I mentioned it. We have atrial, which is mainly characterized by the mitral annulus dilation in an enlarged left atrium. And we have the ventricular MR, which is characterized by a low ventricular ejection fraction and restrictive leaflet motion with tethering of the leaflets due to infarction in the ventricle, or infarction that involves the papillary muscles. Now, very important studies which compared MTER in this setting with optimal medical treatment was the COAPT study. And the COAPT study defined criteria which we now call the so-called COAPT criteria, because the COAPT study came up with a very beautiful and positive result with a hazard ratio of 0.53 in favor of the MTER in comparison to optimal medical treatment. It improved death of any cause, and we now say that it reduces mortality and hospitalization when the COAPT criteria, which are in an LVEF larger than 20% and an end systolic diameter of the left ventricle below 70 millimeters and no too highly elevated pulmonary pressure are there. Those are the COAPT criteria, and this is one of the reasons why we have a very high recommendation for this treatment now. The other one is the so-called Matterhorn trial. That was a trial where the MTER was compared to surgery only in secondary MR, not in primary MR, and it also showed, it was a German study performed at the University of Cologne, it also showed that in this patient setting, the MTER is equal to surgery, and it's associated with less major adverse events. So also in the Matterhorn trial in ventricular secondary MR, we can say that the MTER is not only non-inferior, but it has shorter hospital stays and less adverse events. And then there's a third large randomized study which just came out last year. It's the ReShape-2 trial, which compared the method to optimal medical treatment in patients who were hospitalized for heart failure. So now those were not patients who were stable, but those were unstable patients coming into the hospital, treated with optimal medical treatment, and then treated with MTER. It included 500 patients, 250 in each group. and had a baseline characteristic, typical baseline characteristic, NT-proBNP around 2,600, 2,800 in each group, an LVEF of around 30, and a medium regurgitant orifice area of 0.23 in each group. So those were not extreme MRs. And it showed impressive results. Those are the results that I showed you, those are the patients that I showed you in the middle image. They have decreased ventricular function, they have severe symptoms, but the MR itself is not extreme, it's medium to severe. And they benefit largely in terms of hospitalization for heart failure and in the combined primary endpoint of heart failure or death from cardiovascular causes. So those three studies are the reason that the ESC increased the recommendation from a 2A/B recommendation to a 1A recommendation. So now in patients with ventricular secondary MR, you should perform MTER once they are on optimal medical treatment. I think this is a very important point, at least for our European perspective. How about the atrial secondary MR? We don't have the data for those patients yet. They might come. We know they sometimes benefit very much symptomatically, but do they also benefit in terms of mortality? We don't know that yet. It's still a 2B recommendation. So let me summarize the MTER part of my talk. Mitral clipping is a safe and effective therapy in primary MR patients with suitable anatomy and high surgical risk, also when it's primary MR. In secondary MR in heart failure patients, it improves all-cause mortality and reduces hospitalizations on top of optimal medical treatment, and it has now received a 1A, class 1A recommendation. It should be preferred to surgery when performed as an isolated procedure. That's important when there is a concomitant bypass surgery or something else. Of course, surgery should be preferred. In heart failure patients and patients with atrial SMR, it's likely to improve quality of life and possibly mortality, but that is not so clear yet. So now what about tricuspid regurgitation? This is a different disease. Anybody who knows patients or treats patients with tricuspid regurgitation knows those are very sick patients. I characterize it by patients who not only have cardiac congestion, they also have renal and often liver failure as elevated, shown by elevated liver enzymes. They are often end-of-life patients, and in many, many cases, the tricuspid regurgitation is not an isolated disease, it's rather a secondary condition, secondary, for example, to left valvular disease, to pulmonary hypertension, or to left valvular dysfunction. We've known for long, this is from times when there were only 3 grades for tricuspid regurgitation, that mortality is high when there's severe tricuspid regurgitation. And we know that this mortality is high independent of the reason for the regurgitation. Also, as you can see on the right side, when there's isolated TR, we have high mortality. Nowadays, we talk about 5 stages of tricuspid regurgitation, and that also is important for the decision about treatment with TER method. We start thinking about it when it's severe, that's grade 3 of 5, and then we go on to massive and torrential often is associated with conditions that make it quite hard to actually perform a procedure in those patients, as the vena cava, for example, is so large. We also have 2 types. We have in the secondary form, we have the atrial and the ventricular type. The atrial, as in the mitral, atrial MR is more often present in female patients. The ventricular type is more often present in male patients, and there's a 3rd type, which is, can you start the movie, please? Start the movie. This is the cardiac implantable electronic device associated TR. As you can see in the left picture here, we have a lead, a ventricular lead, which is attached, in this case, to the septal part of the tricuspid valve, and this lead rocks so hardly that it will cause TR. There's been 3 studies that deal with the tricuspid regurgitation TER treatment, and I will shortly run you through that. The first one was the so-called Triluminate study, a large randomized study which included patients at not too high elevated pulmonary pressure, which were stable. They did not often attend the hospital in the year before inclusion, and they also did not have extremely high BNP levels, because at the time of the design of that study, one thought that it should be treated early in the disease in order to receive something. The study was power calculated for an estimated annual mortality of 20%, but it turned out that there was only 10% mortality. So, although the primary endpoint of death of any cause and the hospitalization for heart failure was slightly positive, this was mainly due to an increase in quality of life. There was no signal for mortality, and we think that this is due to the rather healthy population. However, we found, or one could see in the study, that the more severe the TR was and the more successful the repair was, one can say if the grade of TR can be reduced by more than 2 grades from the initial, then patients benefit most. And the increase in quality of life is really astounding. The TRICHEST registry created a score, a so-called TRI-score, which aimed at finding out what would be the right time for tricuspid intervention. On the below left side, you see the TRI-score factors, and when you put those over patients with tricuspid regurgitation, you can see that all-cause death is increased, as well as the composite outcome of MACE and all-cause death, the higher the score is. Now, if you perform surgery, conservative management, or TER in patients stratified by the TRI-score, you find very interesting results. That's what the TRICHEST multi-center registry did. Look at the middle image first. If you have a surgical procedure which is green, it's got similar survival as a successful TER procedure, and it is much better than conservative or unsuccessful procedure. This is not so much the case in the high TRI-score, but it's still much better than an unsuccessful procedure. So the successful transcatheter TER procedure in any case is a very good thing. So the question is, who can be treated successfully? That is not something that is only due to operator experience, but it's also due to many anatomical aspects, which I will shortly run you through. The recommendation in the guideline is a 2AA recommendation, which has been increased from a 2BB because of those studies, but it's not based on mortality. So to conclude with, which are the good patients for TER? Already in 2021, Fabian Prof designed a nice image on the left, which characterized similar liver, renal, or patient factors, which associated with a potential to improve and a symptomatic burden. And he said it shouldn't be too late in the disease process. And now, and also in 2018 already, Philip Lurz gave a nice image of what makes a procedure easy for us. And those are basically 2 factors. The coaptation difference should not be between the leaflets that we want to grasp, should not be larger than 7 millimeters, and the jet should be in an anteroseptal position. We cannot see this in a transthoracic echo. So patients who are referred to us because of an extreme TR do not really we can't already know from that whether they can be treated successfully. We need, can you start that, please? No, before that? Go back. And start both, just clicking on both. Yes? We need a good transgastric view. As you can see here, you have the septal leaflet, and below you have the anterior leaflet. And in this case, you see the TR is mainly between the septal and the anterior leaflet. And this is quite easily treatable. In this patient, if you see a transgastric echo like this, you know this patient is going to be successfully treated. So these patients are very likely to profit or benefit from TEMTR. This is just one procedure. You can shortly run through it as it's done. On the second page, you see the clip within the leaflets. Below, you see the final result. If you want to start it, last one, too. Upper left, lower left? No, he's sleeping.
Florian, we have it.
Yeah, I know. And this is my last image. You see, if it's successfully treated, the TR completely disappears. And this is also due to a ring contraction established through the clips. So now I'm done. Thank you for your attention.